We have just started, so maybe I just start over again. So good morning, good afternoon, good evening, everyone from all around the world. Welcome to today's ACNS YNS webinars. Today, the chair of today is Professor Takeo Goto, who is the professor and chairman of the Department of Neurosurgery, Osaka Metropolitan University Graduate School of Medicine in Osaka, Japan. For the speakers of today, our first expert speakers is Professor Daniel M. Pavadelu, who is the professor of Department of Neurosurgery and director of Minimal Invasive Cranial Surgery Program, also director of skull-based and pituitary surgery program of the Ohio State University Columbus OHUSA. His topic is the role of EA in anterior skull-based meningioma. Our second one speaker is Professor Kyoki Pongo, who is Associate Professor of Department of Neurosurgery, the Faculty of Medicine, the University of Tokyo, Japan. His topic will be a tentorial meningioma presenting with an acute intratumoral hemorrhage. Our third expert speaker is Professor Kalenathan Peliniandi, who is the Associate Professor and Consultant in Neurosurgery, Brain, Spine, and Pain at the Faculty of Medicine, the National University of Malaysia, the University Kebanyakan of Malaysia. We will be talking about the personal experience with cranial medial large fork facet indications and modifications. Our fourth line speaker is Professor Aya Hashimoto, who is Assistant Professor of Neurosurgery of Kurumi University Hospital, Kurumi, Fukuoka of Japan. Her topic would be conference and hospital tour experience in Shanghai and Suzhou. Our discussant today is Professor Mari Kusumi, who is the Director of Neurosurgery, the Department of Neurosurgery of Kitasaku University Medical Centers. And our second discussant is Professor Ahmed Prasad, who is a professor of the Kabul University Medical Sciences. He's also the Chief of Neurosurgery Department of Aliabad University Hospital. He's also the President of the Afghanistan Neurosurgical Society. So without further delay, shall I invite our chair, Professor Goto, today to introduce our first speakers. Thank you, Professor.
Thank you. Hi, everyone. I'm Takeo Goto from Osaka. Today, I'm very happy to chair this wonderful session. That was the first speaker is Professor Daniel Pavadelu. Of course, we know that he is one of the very famous skull-based surgeon and skull-based leader, especially focus less invasive skull-based surgery. So today, his topic is the role of EEA in anterior skull-based meningioma. I'm looking forward to listening to his lecture. Professor Daniel, please start your lecture. Thank you.
Thank you, everybody. Can you hear me all right?
Yes.
Yes.
Perfect. Let me just share my screen and then we can start. Just please give me feedback that you can see well.
Okay.
The presentation here. Perfect. So what I'm going to try to show in around, I think I heard around 15 minutes, right, Dr. Goto? Around 15 minutes?
I don't know that. Doctor.
20 minutes, Prof.
20 minutes?
Oh, okay.
Oh. Okay.
20, you said? Okay, I'll try to be, directly to the point. But yeah, the plan here, thanks so much for the invitation, first of all. Beautiful organization and lots of friends and participation here. So I wish we were doing this in person so I could be in Asia with you guys. It would be wonderful. I'm going to Australia, I think in 1 week, actually. I will be participating with the pituitary event there in Australia. But for today, we're going to show what I'll say, like my philosophy with anterior skull-based meningiomas. We're going to focus on meningiomas to be precise. So what I like to say directly here, the first thing that people think about when talking about meningiomas of the anterior skull base, it's tuberculum cellae meningioma. So I will go directly to this graphic here, because this is an amazing work that my former fellow, Dr. McGill, he did with multicentric, particularly an idea of Dr. McDermott. It's to compare, like, so what is the real difference between going endonasal or going open approach for these tumors? And the main difference that they encountered here was related to vision. So in a few words, the main different outcome was when patients had already vision loss. If the patient already has vision loss, they did better with endonasal approach. In avoiding getting worse vision and also improvement of vision. If the patient had normal vision before or after, or before surgery, so then after surgery, the outcome was similar, and other aspects were similar as well. And of course, endonasal has a higher chance of CSF leak. So how we do these cases endonasal is what I'm going to try to show here. So when you see the anatomy like this, you see the sella, the tuberculum cellae region, the areas of the optic nerve, the amount of bone you have to remove is substantial. I think some people, when they're starting, they don't realize if you remove just to this corner here, you're going to have yourself a narrow space, and you're going to end up leaving diseases laterally. So very frequently, I actually expose the distal ring of the carotid here, and part of the carotid artery has to be exposed in these cases. So the bone has to be removed, so you have a full control of the carotid as you go in. So this is a very important concept. I remember several friends that were starting this, and they came to me like, Danny, like I feel restricted, and that's the problem. Because you need to have this type of visualization afterwards. You need to see the superior hypophyseal, the pituitary stalk, and have full access to the ventral aspect of the chiasm as well, and have control of the anterior circulation, the ACOM area as well. So, so for a tumor like this in our practice, it's really direct access endonasal. So we indicate this coming endonasal for the most part. Very rare exceptions of tuberculum cellae meningiomas when they are larger and they go beyond the clinoids, like that's when we start considering opening approaches. So I'm going to show some of this. So frequently you find hyperostosis on these cases, and we actually send the hyperostosis material to pathology, and it's not unusual for them to see meningioma cells on this hyperostosis. So if you're doing this as a craniotomy, you have to have that in mind as well, because you may not be removing the entire tumor if you don't remove this bone. It's very frequently that we actually find cells. I think it was more than 80% when we start sending this to pathology. So let me just show you here. So this is the planectomy when we remove the planus sphenoidale. Here's taking it off, and then drilling the canal as well. Here's drilling the canal. So very frequently, these tumors, tuberculum cellae meningiomas, they go into the medial aspect of the optic canal. So it's frequent that we actually open, leave it ready for us to open and enter the canal. Here's cutting the this skull base implantation there, just to show how they can be very thick tumors. But with this approach coming endonasal, you actually get to the base of these tumors and you devascularize beforehand. So here's a little more of a plano meningioma, but we can do the debulking. Frequently, we need to use a 45-degree endoscope, as you can see here in this picture. And then after the bulking, we can then dissect. So in this case here, we're dissecting at the area of the tuberculum cellae close to the gland. And you can see beautifully, arachnoid is preserved in the back. So you're not disrupting anything related to the neurovascular structures in several of these cases. So I'm actually walking the implantation of the tumor and trying to keep as much as of that arachnoid alive there. And then here, put a little pledget so the blood doesn't go in much. And then sometimes you see PIA invasion, and then you can do the PIA invasion dissection the same way you would go with a craniotomy. So here we are rotating the capsule of the tumor down, and then eventually bringing it down completely, and then here removing that last implantation of the tumor. So this just shows nicely the technique, how we actually go around the tumor, basically with following the principles of devascularization, debulking, and then rolling it out and dissecting away from the brain. So here you see the meningioma then coming out endonasally. The reconstruction then we've been doing with DuraGen, with the collagen matrix, and then follow with the nasoseptal flap vascularized reconstruction. And so after surgery, you should see the enhancement of the stalk, enhancement of the gland, as you can see here on this imaging. So these are just some other cases. You can see here they can be very implanted on the superior aspect of the diaphragm as well, and you have to be ready. And I pay attention in how much lateral the implantation is. If it goes beyond the optic nerve, it's when I start considering opening approaches. I think that's very important to see the relationship. In this case here, the optics here, I feel that it's still possible, and it was possible. This is the post-op with the nasoseptal flap reconstruction here. The other question people ask, like, okay, but if it goes into the optic canal, like, how do you do those? And this is an example here early in my career. On the left side, you can see here is surrounding the carotid and going into the optic canal. So I used this 𝒂𝒐 scissors early in my career. This is at the end of the resection. Optic nerve is right here, if you can see there. And I'm following that optic nerve. You see the optic nerve is there with my arrow. This is the ophthalmic artery here. The carotid is here. And all the tuberculum cellular meningioma I already resect. But see, there was tumor on the other side of the ophthalmic and also coming into the canal a little bit. So I used this 𝒂𝒐 scissors to go back, but I noticed that it was sometimes not sharp enough, or the angle was not great. And I started working on improving that. See, this is the last piece of meningioma. And here's the reconstruction. You see the stalk and the gland preserved with the nasoseptal flap. Frequently, I will put a little bit of fat under the nasoseptal flap to reinforce. But more importantly, you see no DWI and complete resection of the tumor, including the part of the canal. This is another old video here using the 𝒂𝒐 scissors. You see here the meningioma entering the canal, and you can carry that cutting anteriorly as anterior to the annulus of 𝒚, which it will be somewhere here, as the orbit kind of continues anteriorly. And you can open that like a fillet, like opening both sides. You can see the meningioma, how it shared the space and squeezed the optic nerve there. So over the years, I became more and more aggressive opening that canal to allow the optic nerves to breathe and have space there. But that, you see the olfactory nerve there as well. So these are techniques that I used. And more recently, I started using, see, this is another one. And in this case here, if I show you here, removing the implantation anteriorly, you see the optic chiasm down here. And then a little more into the case here, then let me just show you here. Here, taking the meningioma. And here, opening that canal contralaterally with the scissors here as well. Opening up and giving that space. You can see that the optic nerve really enters right there. And you can see the meningioma coming more anteriorly with it. And very important to get the dura. I use the Kerso 90-degree to bite the dura that has implantation of meningioma as well. And that is very helpful to complete a total resection. And then the image guidance helps, so you know how much anterior you have to go here. And this is opening on the other side as well here. This is the bipolar that is good to control the bleeding on the corners. And here's the final view here with ICG that you can use to show the structures as well. It can be helpful. And this is the way I've been doing more recently. I actually opened the canal with this knife I helped to design. So here is blunt on the side of the nerve. So I just hook there and slide all the way anteriorly. And this is very fast, much easier. That's the way I do these days. Have to remember that always a little bleed from the dura. The dura is vascularized. There's some of these meconial arteries that come from the carotid. So you got to be prepared to do a little bipolar on the dura and be careful with the optic nerve. But it's very, very fast way to open all the way to Lavzine. And that's the way I've been doing more recently. So here shows some of these little larger tumors. This was a 48-year-old lady, and she was functionally blind with this lesion. This is the first time I thought about staging these tumors because I felt that would be very difficult to remove everything with an open approach without affecting her vision. And you see the tumor goes to Sylvian fissure here. And I was like, well, my God, this is not something that I thought could be done endonasal. Interestingly, though, I was able to get a very nice exposure, and you can see the bifurcation of the carotid right there, and the anterior cerebral, you see by transparence through the optic nerve there. Anterior cerebral arteries are right there. And by manual resection, very important here, dissecting from the superior hypophyseal arteries on both sides. And you can see this, we're actually able to get the whole tumor out. And the stalk is preserved, bifurcation, MCA is there. The tumor rolled from their area. See the pituitary stalk here, the carotid is there. Everything was able to resect. The patient did very well and was only one stage. But this was the first time that I thought about maybe I would debulk, and then later I'd come back and do a craniotomy. That's what I told the family I was going to do, and eventually end up taking the whole tumor out. But this opened my mind in terms of like maybe for some cases that's one way to do this. Here, let me. So these are other smaller tumors. Here's sometimes. For smaller tumors, it's really nice because you don't really need to open as much. This is a patient that had a small meningioma, and she was losing vision on the left side. And I opened this, let me go just directly to the point here, opening the dura. I mentioned earlier, I opened with the Kerrison, and then just PT tumor, nicely located, and the tumor just herniated out without opening the arachnoid very nicely. And you can see here rolling it out. She, again, was losing vision on the left side. Very subtle, though, very subtle, but enough for me to indicate the surgery. So for the small ones, like, it's amazing coming endonasal, much better for the patient than if you did from the other side, because this was under the optic. So if you come ipsilateral with a craniotomy, it's going to be a blind spot under the optic nerve. And we did a little bit of ICG and roll this tumor out of there. Let me just show you here how after we roll it out, you see the optic nerve there, and the arachnoid is still preserved. So very nice way to do it. And here we got that small tumor out, not so big. And then we did ICG at the end. You can see, make sure the tumor was all complete resection, and you can see the superior hypophyseal artery there preserved as well. And again, the reconstruction here we'll do with the nasoseptal flap, and I do a soft gasket seal that I call with the collagen. So these are examples of tumors that we've done early in our career. Like, now we're probably getting close to 100 of these meningiomas, tubercle ocelli. But this is important to see that we do an MRI and make sure that you have enhancement on the stalk and the pituitary gland, and the nasoseptal flap is enhancing as well. So for a little larger ones, we create this algorithm here, Dr. Goto, where we look at smell as the most important thing. For the anterior skull base, more anterior. If the smell is preserved, the smell is normal, I do craniotomy. Because going through the nose, you're going to end up causing problems with the smell, and quality of life is very important. With the craniotomy, it's more likely that you will be able to preserve. And if the smell is gone, then I think about, okay, so the tumor is large, but I think I can get everything endonasal. So I go endonasal and remove the tumor because the smell is already gone. If the smell is gone, but the tumor is gigantic, go lateral to the skull base, I've been doing 2 stages. One stage, I go endonasal and debulk the tumor and devascularize the tumor, and then I come back open and remove the rest. So to do that, very important to understand the anatomy of the anterior skull base. The anterior and posterior ethmoidal arteries, they give blood supply for these meningiomas of the olfactory groove. And it's very important to do a draft 3 endonasal, exposing the posterior wall of the frontal sinus, get a full control of the cribriform, because all this is going to be removed to get your complete resection of those meningiomas. And the posterior limit laterally are basically the optic canals as well. So you can go all the way down there for some of these tumors. So plano meningiomas like this, in this case, this patient had normal smell, but it still was not in the olfactory groove. So this is the only exception that I still could do endonasal, but understanding that is difficult because you have to do the whole surgery with a 45-degree endoscope and try to preserve the olfactory nerves anteriorly there. On the left side, I was not able to preserve the olfactory nerve for this lady. She had normal smell. This is the frontal polar artery that we are microdissecting and releasing from the tumor. And then on the posteriorly, we dissect from the arachnoid, and then here on the dissect from the anterior pia dissection. And on the right side, actually, we're able to preserve. If you look up here, that's the olfactory nerve preserved. So this is an exception case where we preserve the septum and preserve the anatomy of the smell, because the tumor, you can see here the olfactory nerve, and the tumor was not going into the olfactory groove. So that this patient, we were able to preserve this anatomy here, preserve one of the nerves, and she actually preserved the smell. Initially, we tested, it was not there, but about 3, 4, 6 months, and it starts coming back, and she has the smell normal. Now, for larger tumors, this is a tumor that I actually remove endonasal because I felt that could retract the periorbit and go all the way there. I'm not going to go through the whole video here, but you can see mobilizing these larger tumors from endonasal is possible. And you can see how pale it is after you devascularize them by coming endonasal, because you got the ethmoidal artery. So this is an example of large tumors done endonasal. This is the resection post-op. And the most important aspect is that if you remove these tumors, they have a lot of edema. You go from the nose, you don't fight the brain. And afterwards, the edema gets better. And we publish on this aspect. See this impressive edema, then you don't see that footprint in encephalomalacia afterwards. So that's one of the advantages of coming endonasal. The problem is like tumor like this, I felt like, okay, so we got to do endonasal historically. I did this in 2 stages. I was young and didn't understand this implantation right here. It was too lateral on the anterior clinoids. So although I was able to remove this, and I'll show you here, dissecting from the brain and also dissecting from the anterior cerebral arteries, that's the chiasm. And I was able to dissect, as you can see here, from the anterior cerebral arteries progressively there, got this type of resection and a little bit of residual on the left side here because I was not able to lateralize on top of the optic nerve. So the resection was good, but 5 years later, you get a recurrence, and that's the problem. I had to take this patient back, a craniotomy 5 years later, and it was not easy to remove everything because of the scar, and you have to have that in consideration. So tumors like this, again, when they are larger, but they are restricted to the axis, I would do endonasal because the smell is already gone. And we publish on the fact that you have less of a footprint on the brain with no encephalomalacia. So it's very possible to resect larger tumors, but it's very important to take in consideration the smell and the lateral implantation. If the tumor has lateral implantation beyond the optic nerves, particularly, or beyond the meridian of the orbits, then you should consider a 2-stage or open approach. Have to always remember that there's some cases that actually mimic olfactory groove. This is not olfactory groove, it's a parafalcine meningioma. So this here, you don't want to go underneath here because there's brain. If we open the dura here, there's brain. So this is, we did a craniotomy, came from the top, and you can see here the craniotomy, and just have to differentiate. The other aspect is this, like, look, if go lateral implantation, we're gonna go quickly here just to finalize, Dr. Goto. And this, we did an eyebrow incision. You can see the incision here. Eyebrow is very nice to go on the anterior skull base and remove this because of the lateral implantation, go with the craniotomy. This is another one. The patient had smell. And you can see here the olfactory groove is normal on the left, on the right, and the left is coming down. So for this, I did a craniotomy and preserved the olfactory nerve on the right side, and the patient had normal smell afterwards. And then I'm just going to show a couple of principles here to finalize. This patient was operated by another neurosurgeon via craniotomy. They did a good job. Not much of a footprint on the brain, just a little more encephalomalacia there. But the problem is the hyperostosis was left behind. 10 years later, came back with this recurrence, and I then came endonasal to remove this and was able to complement the resection of the craniotomy that was not complete. So that taught me this principle. So for tumors like this with hyperostosis, now I come endonasal, remove all the hyperostosis, I devascularize the tumor, and I make a hole on the center of the tumor. It looks like this. So devascularize, collapse. And now I just need a small craniotomy 2, 3, 4 months later, and I don't need to do a big craniotomy to take this tumor. And I just came from the corner here and took the rest. So that's what I call a two-stage approach. And that basically finalized my thoughts about this. When you come on the second stage, I don't use retractors. You can see here dissecting after the stage 1. It's a typical craniotomy here. And the brain is more relaxed on the stage 2. The edema is not quite there. And interestingly, this is the way it looks like at the end. Let me just show you here the aspect of the skull base. You can see the optic nerve there, clear the other optic nerve, and the skull base with the nasoseptal flap that was used for reconstruction. So the interesting thing about this is that the endoscopic approach, I end up doing bigger tumors than open, because open are the patients that still have a smell. So they are little smaller tumors that I did open and preserve smell in the majority. And endoscopic smell is already gone, and the large ones I staged. So the very large ones that we did staged in our practice. This is just some of the statistic. And as I mentioned here, the majority of open approaches, with the exception of one patient, like the smell got worse. But the endoscopic here, there's one patient that had a little bit of smell that lost, but it was hyponosmia. And the stage 1, they didn't have smell at all anymore. So in conclusion, I think we have to favor and always look at function. So smell is very important to take in consideration, and also the size and implantation of these tumors. So we just had our course. Is going to be now next in the May of 2025. For those interested, please let me know, and we will be happy to have you with us. Thanks so much.
Thank you, Daniel. Your lecture, the very educative for the young neurosurgeon. I always agree that the strategy to minimum the invasive surgery to anterior skull base tumor. I have just one question about the surgical strategy of large olfactory groove meningioma. I also use the same strategy. At first, perform the endoscopic endonasal approach to decompress the tumor. And then after that, I reject the tumor eyebrow keyfold approach to resect as a second surgery. But I made one complication. I operate a very large skull olfactory groove meningioma. After partial resection of the tumor, frontal base herniate to the nasal cavity. Do you have such a complication or no?
Yes. So it's part of something I didn't mention, but the very large ones, I try not to expose the brain. So if there's a more anterior part that there's brain there, I keep it dura there. Yeah. I carefully don't expose the brain because of that, because I had 1 or 2 earlier, the first few that I did. I actually like the large ones that I do decompress, I devascularize, and I stay inside the tumor only, and I try not to see any brain. Sometimes there is not even leakage because I stick the tumor and the implantation seals all the areas on the corner, and I still put a flap then to come with the craniotomy afterwards. So it's very important to be careful not to expose any brain, because it is true there is edema and the brain starts coming and you want to keep it dura. So if I see a little brain, I stop there, put a little gel foam, and I continue doing the devascularization and the decompression. But very important point. The other important point, since you brought up complications, is that I've been studying now the venous drainage of these tumors, Dr. Goto. Do angiogram beforehand, and because I had a complication as well where the tumor got venous infarct by filling the skull base before taking the arteries. So what happened is some of these tumors, they drain venous to the brain and posteriorly. Those are perfect to go with this technique. But if they drain venous through the skull base, you need to make sure when you're doing your first approach, you need to take the arteries first. It's like an AV, it's like an AVM. You want to take the arteries first and then drill the skull base, because sometimes you drill the skull base, there's big pipes of veins draining that tumor. So if you then use like hemostatic agents before you take the arteries, the tumor will inflate. And I had a patient that had a complication because of that. So you want to make sure you get the arteries first.
Yeah. Daniel told us a very important point. When we plan the decompression surgery, not expose the brain is very important to prevent the complication. Thank you, Daniel. Do you have any question from the audience? Professor Kato Sensei?
Hi, can I ask him? Daniel, thank you very much for excellent talk. Thank you so much. So the last part, can you make sure if this is artery or vein? Because of course sometimes when we do the ABM surgery, it's quite difficult to make a differentiation. Artery and vein. Is it easy to recognize?
Yeah. So in this case, the blood supply comes from the anterior and posterior ethmoidal arteries. They come from the orbits, like 2 and 2. So, and the middle is where the venous drainage is happening through the bone. So my point is, if you start drilling the bone and you end up getting to veins through the skull base, then if you use a hemostatic agent or bone wax and you seal that, you may actually decrease the venous drainage of the tumor, and the tumor may inflate because the arteries are still alive, feeding the tumor. So if you start the strategy and bipolar the arteries, and they are arteries because the ethmoidal arteries are anatomically normal, not like an AVM, but with the principle that the blood supply is coming. So if you take those first, then the tumor will collapse and get shrunk, and then you drill the hyperostosis or may have drainage of veins. That's my point. So it's similar to an AVM in the sense that you want to take the vascular arterial component first, supply, to then play with the potential venous drainage to avoid a venous congestion or venous infarct of the tumor.
Yes. Okay. Thanks so much.
Thank you.
Dr. Sensei?
We have the many questions from the audience. So that was Professor Maki Kusumi, please.
Thank you, Chairman. Thank you very much for your wonderful lectures, Professor 𝒂𝒏𝒂𝒂𝒂𝒂. I have one question about for the tuberculous meningiomas. You said last case is a very big one to laterally to the Sylvian fissures. That time, the tumor is not adhered to the around tissue, so you can take out all of the tumors. But if it is adhered to the artery or something, how do you decide to stop the surgery?
Yeah, it's very important. I think, it is a tendency that we bring to these courses or our presentations, the beautiful cases, but there are some ugly ones, as you mentioned, that is adherent to the optic or adherent to the arteries. I shave it down and I try the best I can to peel If it's not possible, I leave a little layer on those structures. I think this is very important. Not too long ago, I had to leave a piece that was around the anterior cerebral artery. So it is a patience process. You have to inspect, analyze the bulk, get closer. Sometimes you're lucky and you were able to remove everything, but sometimes you need to make that decision to leave a little bit around those arteries. The good thing, majority of these tumors, they're not like that, but they're definitely, I would say, about 5–10% of them, they can behave very aggressive. I think there's another entity that I like to bring here, maybe for the first time. There's some tumors we call tuberculum cell meningiomas that they actually are carotid, optic carotid tumors. They actually have the base there on the carotid. Like they come from arachnoid cells, I guess, on the medial to the carotid, and they push the optic up. Those are more difficult to take it out, endonasal or open, because it's really in a difficult corner. And those are the ones that when you look as a tuberculum cell that is eccentric to one of the sides, those are the ones you have to think that they may be implanted on the base of the carotid. Those are more difficult because they're like stuck there, and more likely for us to need to leave a little bit on the carotid.
Oh, thank you. You are so wonderful lectures. And also, do you use an ultrasonic aspirator to debulk the tumor, or you do other instrument?
I do for the very large ones. For the tuberculum cell meningiomas, I use the myriad device, the NICO, that aspirates and cut on the side. That is, it's a nice way to debulk, and I think is more precise because on the side. What I don't like to combine a 2D endoscopic that you don't have a perfect 3D visualization with the suction that is on the tip, which is the ultrasonic, because you may go too deep with that. So you just gotta be careful. For the very large olfactory groove meningiomas, I do use the ultrasonic, and I actually study my depth of how much tumor is still there with the ultrasound these days.
Thank you so much.
Thank you. So we can have another just one question because the time is limited. So Professor Atiq, do you have any question?
Yeah, thank you, Professor, for your brilliant presentation. It will surely enlighten the young neurosurgeons. Very just simple two questions. Sometimes it is difficult to peel out the tumor from the vessels, and sometimes the tumor like TSM is firmly adhering to the pituitary stalk. So what is your strategy? Do you leave some tumor which cannot be separated, or you have some technique to peel out the tumor from the structure like pituitary stalk or ACA or
so it's similar to the other question. If I have to leave something, I'll leave something. But I'll tell you, for the pituitary stalk, my strategy is to go on top of the pituitary gland and detaching from the diaphragm until I find the stalk. That helps me to understand the depth of the tumor by coming endonasal. I lift, and frequently I get CSF that comes on the side, and I see where the stalk is behind the tumor, and I try to lift that up, similar to what you're going to do to take a schwannoma from the facial nerve. You find where it takes off, and then you kind of keep falling, bringing in your direction, kind of falling the stalk up. And then that's the way I do. If it allows me to detach, I would. But if it is really stuck or I stuck on the superior hypophyseal artery there, I may need to leave a little behind. But it's I don't remember leaving much on the pituitary stalk in my career. I have left disease on the optic nerve, very stuck, and also in the anterior cerebral arteries. That's the more common area that they will be very stuck.
Thank you.
Okay, so thank you, Professor Daniel. We have another question, but please send the Q&A. Maybe Daniel will answer the question.
One question to go to center, just one.
Dr. Ben, time is okay?
Yeah, I think maybe just the last question, and I think we should proceed.
Thank
Yeah.
you. Sensei, for this anti-scalability approach, the management of the paranasal sinus is very important for the exposure purpose. So do you have any tips or how do you address the paranasal sinuses in olfactory group meningioma, plana, or tuberculosis? Thank you.
I don't know if I understood, like the related to the frontal sinus, you said?
Like in olfactory group meningioma, you have to go with the Lothrop technique. If you want to go the bimanually. So how do you address the paranasal sinus? I mean the ethmoid sinuses. Do we keep all the paranasal sinus open like the ENT surgeon does the face functional endoscopic sinus surgery? Like you open all the paranasal sinuses or what?
You said cavernous sinus?
No, I'm talking about the paranasal sinuses. Like when you want to do endoscopically the olfactory tube meningioma.
Oh, you're talking about the ethmoidal sinus and sphenoid sinus and all that. Okay. Yeah, so to be short here for the time, it's true, like a very open approach. So I would do ethmoidectomies on both, particularly on the right side where I have the camera, completely anterior and posterior ethmoidectomies and exposure of the sphenoid. For the anterior skull-basal olfactory groove is bilateral anterior and posterior ethmoidectomies with the exposure of the frontal sinus. Sorry, Dr. 𝒂𝒏𝒔, there was a little crack on the sound, but I understood your question.
I mean, you also open the frontal sinuses. I mean, you keep open the frontal duct.
Correct. That's the draft 3 that I made.
I just wanted to. Yeah. Thank you.
Thank you.
Okay, thank you, Daniel. We learned a lot from your very educative lecture. Thank you.
Thank you.
So now we move to the next speaker. Next speaker is Dr. Hiroki Hongo. The title is tentorial meningioma present with acute intratumoral hemorrhage. Please start the lecture, Professor Hongo.
Yes. I'm sharing my screen.
Okay, we are seeing the other screen also.
Yeah.
Okay.
It is okay. Okay. Hello everyone. I'm Hiroki Hongo from the Department of Neurosurgery at the University of Tokyo. I'm very happy to be here and have a wonderful opportunity to talk. And thank you very much for inviting me. Today I like to talk about a case with a tentorial meningioma presenting with an acute intratumoral hemorrhage. First of all, hemorrhage associated with intracranial meningioma is rare. As you know, meningiomas are the most common benign intracranial tumor, and we often have patients with meningiomas. However, it is rare. We have meningioma presenting with acute hemorrhage. Recently, we experienced a case of tentorial meningioma presenting with acute hemorrhage and successfully treated by surgical removal. So I'd like to describe the case and discuss the treatment strategy for the tumors. I'd like to present our case. Our 68-year-old male had with a prostate cancer, had a brain MRI or a screening, and was incidentally diagnosed with a tentorial meningioma. And our doctor in charge started follow-up. However, only 1 month later, he developed a sudden hemorrhage and vomiting and consulted a local clinic. And he had a brain CT scan and diagnosed to have a hemorrhage in his posterior fossa and transferred to our hospital and admitted. He has the chronic kidney disease and was under hemodialysis, and he had a prostate cancer and hypertension. He had some medications associated with hypertension and chronic renal failure. However, he didn't have any medication, any antiplatelet or anticoagulant drugs. And blood exam revealed decreased renal function, but the data didn't show any evidence of coagulopathy. And the neurological examination indicated that his consciousness was alert and he had left cerebral ataxia. This slide shows the MRI at diagnosis. The MRI shows an extra-axial tumor in his posterior fossa. The tumor is attached to the cerebral tentorium. And the tumor was small, and there was no edema around brain edema around the tumor. And the doctor started follow-up. However, after 1 month of the diagnosis, he had a sudden onset headache and vomiting, and had a CT scan, which showed high density area in his posterior fossa around the tumor. And these images also showed peritumoral edema, and transferred to our hospital. And the surgical images also shows the high density area around the tumor. We performed an MRI without MRI, a non-contrast MRI, because he had a severe renal function. And those MRIs also showed there was an hemorrhage around the tumor, especially in the posterior caudal area of the tumor. And also showed a large edema around the tumor in his vermis and the left cerebral hemisphere. And the T2 weighted image and the T1 weighted image also showed the hemorrhage clearly. We performed visual subtraction angiography, and that showed a slight tumor stain under the cerebral tentorium. The tumor was fed from posterior meningeal artery originating from right vertebral artery. The CT angiography and the venography is shown. The left transverse sigmoid sinus was less dominant, where the tumor was located. And for differentiate the tumor from the other tumors, including malignant tumors, we did a FDG PET. The head image showed the tumor was low uptake, and the body image didn't show any other abnormal lesions showing high uptake. Corresponding to the consideration of us that the tumor is a relatively benign meningioma. And this to prevent the second hemorrhage and the subsequent neurological deterioration, we decided to perform surgical removal of the tumor. We constructed 3D fusion image using several imaging modalities of him, and this shows the tumor. The colored purple is the tumor, and hematoma is also shown. The tumor was fed from posterior meningeal artery. This includes the veins and sinuses. There was an inferior vermian vein medial to the tumor, and there are some other bridging veins and transverse sinuses. But the bridging veins were not so complicated, we thought. This also shows cerebral tentorium. This is left to right view with cerebral tentorium. this is superior view. The tumor didn't have any component supratentorial. And the left inferior hemispherical vein was identified laterally to the tumor, and which was draining to the tentorial sinus. Those veins were seemed to be attached to the tumor. This is inferior view showing the inferior mammalian vein, which is also attached to the tumor and draining into straight sinus. And so altogether, we thought these images showed the not so complicated breaching veins, supracerebellar, and the tumor was only had a component infratentorial. So we decided to perform surgery via supracerebellar route. This is the supposed operative view. After posterior craniotomy and dural incision, the tumor was supposed to be seen supracerebellar. There was a couple of veins attached to the tumors, and we thought we had to be careful to not to injure these veins during the removal of the tumor. And this is the operative video. And under general anesthesia, he was positioned in prone, and left hockey stick shaped skin incision was designed. And the skin incision midline was performed, and it was extended to the left. And the skin was retracted, and 7 Bajo craniotomy was performed, including a trochlear bone, where the bone is very thick. And after some bones were drilled, we incised the dura. Introduced surgical microscopy. The left is cranial and the right is caudal. The tumor was seen supracerebellar, and we can identify the veins around the tumor. The tumor was not so different from normal meningiomas surgical microscopically. And the frozen section diagnosis was meningioma. We started the detachment of the tumor from cerebral tentorium, being careful to not to injure the around veins. And after completion of the detachment, we started the removal of the tumor using ultrasonic aspirator and scissors. And the tumor was gross totally removed. And after that, we coagulated the cerebral tentorium where the tumor was detached. And the dura biopsy was performed. Bone flap fixed, and the skin was sutured, and we finished the surgery. And this is the post-operative. This shows the post-operative CT showing the gross total removal of the tumor, and which didn't show any obvious complications, including hemorrhage. And post-operative MRI also showed the total removal of the tumor. Postoperative day-one MR didn't show the left transverse pneumonoid sinus clearly. However, 2 months later, the MR showed the left transverse pneumonoid sinus as same as preoperative condition. And the histology was transitional meningioma, one type of 𝒂𝒏𝒔 and one meningioma, and the median leveling index was 10%. This slide shows the latest MRI images 21 months after the surgery, and there was no evidence of the recurrence of the tumor. And so I like to show some slides for discussion. The hemorrhage associated with intracranial meningioma is rare, and some studies reported the incidence to be approximately 0.5 to 2.4% of all meningioma cases. However, the mortality rates of those patients is as high as approximately 30 to 50%, although the referred papers are relatively old. And in terms of risk factors for hemorrhage, spontaneous hemorrhage in meningioma is not related to sex, age, blood, blood condition, hypertension, or tumor location, according to the previously reported previous reports. However, our patient had severe renal function and was under hemodialysis, so he didn't have any coagulation drugs daily, but the anticoagulation during hemodialysis might affect the hemorrhage. And in terms of histology, a study reported a high risk of bleeding in malignant meningioma. However, the majority are manifesting hemorrhage are benign, as like our case. And in our recent systematic meta-analysis, the 90% of meningioma with acute hemorrhage was grade 1 tumors. On the other hand, hemorrhagic meningioma has been frequently reported in Asians compared to the other ethnicities, suggesting this might suggest that there was some kind of genetic differences in blood coagulation. And finally, about the treatment strategy. Although acute intratumoral hemorrhage were in meningiomas, there are some studies showed recurrence of hemorrhage from meningioma, and but the duration between the first and the second hemorrhage largely varied from 36 hours to 33 months. And also the location of the tumor and histology of the tumor was varied. So it is difficult to expect the clinical course after the first hemorrhage of a meningioma. However, given the poor prognosis of meningioma patients with hemorrhage, we think early removal after the first hemorrhage is favorable. In conclusion, we experienced a rare case of meningioma presenting with acute hemorrhage. It is currently difficult to predict the clinical course after the hemorrhage. At the first hemorrhage, it is preferable to be removed early after the first hemorrhage. That's all. Thank you. Thank you for your attention.
Thank you, Professor Hongo. Your lecture is very educative, and you presented a very rare case of the meningioma showing the intratumoral hemorrhage. So do you have any question or comment from audience? So,
いいですか、後藤先生。
Daniel.
Daniel raise a hand. Daniel.
I just want to
first.
say, okay, I just want to make a comment. I only seen these apoplexy events in adenomas, pituitary adenomas, and chordomas. I have 2 cases of chordoma that bled preoperatively. Meningioma, very unusual, very interesting case. Just want to congratulate.
Thank you very much.
Do you have another question?
So, Hongo Sensei, thank you very much. So, just I want to ask, do you have any special attention because the location is posterior fossa? So many vessels is related with the tumor. So maybe you can compare with the anterior skull base and also what you have more attention when you treat with the posterior fossa meningioma. Just let us know, please.
I by chance experienced the tumor in the posterior cranial fossa with hemorrhage. So I done any detail and consideration about the location of the tumor with acute hemorrhage. So this is, I think, a rare case of a meningioma, and as reportedly, there are no obvious tendency of the location of the meningioma with presenting with acute hemorrhage. So this is just a rare case, and in my small experience of the tumor.
Thanks so much. Excellent presentation. Congratulations.
Dr. Ben, do you have any question?
Yes, and very interesting case, Congo. So I just want to clarify that is tumor embolization has tumor embolization performed, and if in your center, if tumor embolization need to be considered, usually what material you use and what is the time interval between the embolization and operative treatment.
In this patient, we didn't perform a preoperative tumor embolization. So, but because the digital subtraction angiography preoperatively didn't show vascular much vascularization of the tumor. So we performed just surgical removal, and unfortunately, the tumor didn't have any didn't show much hemorrhage. Unfortunately.
Thank you.
Okay, so Professor Maki Kusumi, do you have any question?
Yes, thank you, Chairman. Thank you for Dr. Hongo. You have show us a very rare case. So if meningioma hemorrhages happened, do you think emergency surgery is needed for the patient? I mean, maybe this is depend on the patient condition, but you said second hemorrhage will be happened during 36 days or something. Do you think you need emergency surgery for this kind of patient?
Thank you very much for your question. I don't have I may not have a good idea, but at least in our case, we he firstly admitted to our hospital and have a detailed imaging examination such as MRI, CT, and actually we constructed 3D fusion image. So, and fortunately, among the pair, he didn't have the second hemorrhage. So, in my opinion, it is preferable to have examinations to do fine surgery rather than thinking the risk of the second hemorrhage or overly. So I think it is better to not to do surgery so hurry. We should have a detailed examination before preoperatively, I think.
Thank you.
Okay, thank you, Professor Hongo. You
Yes.
showed a very rare case of the meningioma showing the intratumoral bleeding. So, thank you, Professor Hongo.
Thank you very much.
We move to the third speaker, the Professor Kamarantan. Is it correct, the pronunciation?
You're about 80-90% there.
Yeah. Professor Kamarantan present the personal experience with cervical medial branch block, the indication and the modification. Please start your lecture.
Thank you, Mr. Chairman. Okay, I need to apologize for my webcam not working. It was working like, at the beginning around 6 p.m. and then now it's not working. So can you all see my slides?
Yes.
Thank you. Okay, so I will be letting everyone to have a short break actually, because everyone is talking about the heavy topics of the brain. So I'll be talking a little bit on how do we relieve some pain in the neck. So I'm not going to be very academic and let's see. Okay, so what would the indication for medial branch blocks be? Is basically for pain of the neck originating from arthropathic changes of the facet joints. So basically it's osteoarthritis of the facet joints, and it's basically because of repeated mechanical stress to the neck. So a little bit of background, right? Facet joints are symmetrical synovial joints with fibrous capsules that connect the articular facets of the vertebrae. So they've actually done mechanical stress studies, and they say that approximately 20% of the weight which is carried by the spinal column is carried by the facet joints, as opposed to about 80% is carried by the vertebral discs. However, when we compare the surface area, per surface area, the amount of stress which is taken by the facet joints is much higher than compared to the intervertebral joint via the disc. And why do I think it is important? Because it is one of the most common sources of spinal pain syndromes. And out of all cervical, neck pain cases, about 55% actually have facet origin, right? And as we go down for thoracic, it drops to about 40%, and lumbar, it drops to about 31%. So a little bit of anatomy. The medial branch actually originates from the dorsal ramus immediately after becoming the spinal nerve, and it follows the pedicle towards the respective target muscles, such as the multifidus, semispinalis, and cervicis muscle. And generally, a cervical facet joint receives a medial branch from the dorsal ramus of the spinal nerve above, as well as the one below. So for the example will be, for a C4, C5 facet joint, it actually receives medial branches of the dorsal rami of the C4 as well as the C5 spinal nerves. And why I emphasize particularly C4, C5, because theoretically and as well as what's been reported by others and my own personal experience, the most common site of facet joint pain or tenderness would be the C4, C5 facet joint. Okay, and there's a little bit of variation whereby the innervation of the atlanto-occipital and the atlanto-axial joint, the C0, C1, as well as the C1, C2, is derived from the C1 and C2 roots respectively. And the C2, C3 joint is supplied by the third occipital nerve. Now, this third occipital nerve is part of the greater trigeminal complex, which also gives us the innervation of the greater occipital nerve as well. In the cervical spine below C2, C3, the facet joints, as mentioned earlier, are supplied by the vertebral nerve rami of the joint, the above and below. So now, the distribution of pain, patients with cervical facet joint pain often complain of neck and shoulder referred pain. So this would be one of the salient points when they say that the neck is painful, at the same time the shoulder is also painful or stiff. Some patients would actually say that, look, my shoulder joints or my shoulder feels it's rock hard. And the most common affected facet joints would be C2, C3, whereby the referred pain is distributed the nape of the neck. And it also actually extends up to the superior temporal line. And in my practice, actually, many patients who failed headache treatment, whereby they've been diagnosed as having cluster headaches, they've been diagnosed with having migraines. Somehow the culprit is actually the C2, C3 joint. And giving a block over there would actually give sufficient improvement to the pain. Now, as I mentioned earlier, C5, C6 referred pain is distributed the supraspinous area. So shoulder, right? And the C6, C7 referred pain is distributed infraspinous as well as the interscapulary area. And pain referral regions may seem to be similar to those of the upper thoracic facet joints, but they do not involve the flank. Meaning the cervical facet joint pain referral region, right, especially the lower ones, C5, C6, sorry, C6, C7, would be more midline compared to the thoracic facets. So again, this is a diagram by Bogduk et al. Right, in 1976, they actually went about injecting saline into the facet joints, and then they actually induced pain. So this diagram basically shows where the referral of the pain of the various joints goes to. Oops, sorry. So in terms of investigations, they are actually essentially clinical diagnosis. The cervical X-ray is actually used to rule out associated instability, because instability pain may mimic facet pain as well, but they tend to be more bilateral. But having said that, typical facet joint arthropathies, they do happen bilaterally, except that there's some asymmetry to the pain. MRI, yes, in the presence of red flags, radiculopathy, neuropathy, myelopathy, yes, I would actually advise for MRI prior to any procedure. So in my practice, what I do is, of course, localization prior to doing the procedure. So I mark out the area of facet tenderness here. And then subsequently, I localize using the image intensifier. Preparation of my tools of trade. So this was actually taught to me by another more senior surgeon. I tend to standardize my syringes. So the 3cc syringe is used for contrast. The 5cc syringe is used for local anesthesia for skin infiltration, which will be lignocaine. And the 10cc syringe is used for the actual infiltration into the the medial branch. So this is commonly what I do is I would use 0.1% ropivacaine. With dexamethasone, I do not use, I mean, it's always been generally advised that not to use particulate steroids. So because of association with venous infarction. And the whole thing is just diluted. So the most important salient point here is, it's not so much about how much of dexamethasone we're using, but we need to ensure that the concentration of the ropivacaine is at 0.1%, because anything higher than that, then we are a bit concerned about the motor block which it causes. And of course, again, I localize with my image intensifier. And I tend to do more of patient in prone position. These were earlier days when I was approaching in a more posterolateral approach. And of course, squaring, that is very important. I mean, any one of us who does spine practice would want to do squaring. So basically here, this image here is not well squared. This is much betterly squared. Right? The lateral masses are in sort of a rhomboid manner with both sides, the left and right rhomboids, overlapping each other. And this image here is basically a cross section. So what we are trying to avoid is basically the vertebral artery. Traditionally, we used to approach from more of an anterior approach, with the patient being in supine position, but I find prone position much more better, because you get sort of a direct approach, and you know that you're going to avoid the vertebral artery. One of the questions which people always ask me, now patient is in prone position, won't they feel suffocated? I actually elevate the shoulders with standard pillow. Hello? Hello?
Yeah, Prof, we can hear
Oh,
you.
sorry, because my
Yeah.
my screen went blank for a while, sorry.
Okay.
Oh,
Okay. It works now. It works in our when
all
we see
right.
it.
All right, lovely, thank you.
Yeah, please continue.
Okay.
Thank
Yep, so in prone position, so and the forehead is elevated with a towel roll approximately 3-4 centimeters. Therefore, the patient actually has got quite a bit of space to breathe. The nose is not touching anything. So to me, they're actually more comfortable in that manner. And I get to actually approach the joints from C0, C1 all the way down to C6, C7. Some thinner patients actually can even get C7, T1 if I want to. Again, placement of needle, contrast. Okay, this is another patient, and this is exactly how I place the patient. So there is a towel roll actually here, and the shoulder is elevated with another pillow. So the neck is sort of bridged, and the neck is more in a flexed position. So I'm approaching the patient's left. I think most of us who do pain practice would know, just try to place the needle smack at the middle of the rhomboid as much as possible. the other advantage which I noticed with this prone position is I can actually needle both sides at the same time. Therefore, I reduce the time, reduce the repositioning the patient. The radiation exposure is much less as well. So here I've already placed this is just to show that I to prove that that I'm not lying actually, because some would say that, hey, maybe you have done. So now I've got all 6 needles here, and usual contrast infiltration. This is a bit off, but then it still worked for the patient. Again, needle. Yep. So now there's an issue with variable innervation. Sometimes when we give injection, it doesn't work that well. So that is because they've done studies and they show that the majority actually have multiple medial branch innervation, single level. But then there's also double innervation at multiple levels, and there's also a plexus-like pattern. The higher we go up, the more the plexus-like pattern. All right, and I would like to thank you for giving me the opportunity to share my experience.
Thank you, Professor Kamalan. Nice talking about the local anesthesia or blocking of the facet joint for neck pain. Do you have any question from audience? Dr. Ben, do you have any question?
Yes, and thank you so much, Professor, for your interesting lecture. And pain is often a neglected specialty in neurosurgery, and thank you for bringing this out. And this very important aspect in neurosurgery to treat the pain, and also for cervical pain especially. I would like to ask about during your procedure, what is the anesthesia that you use? What is the mixture? Do you use a long-acting lidocaine, and usually how long would the effect last? And during the procedure, and do you need to have any nerve monitoring and during the procedure? Thank you so much.
Thank you for the question, Dr. Ben. Okay, in referring to the anesthetic agent, I like to use ropivacaine. You can use bupivacaine as well. So these are relatively long-acting agents. You would anticipate them to last for up to about 4 to 6 hours. And so normally what I would do is with pain practice, the most important thing is actually managing patients' expectations.
Yes.
Right? And with this multiple variability of innervation, so never overpromise the patient. Tell them to expect for reduction in pain, not complete elimination of pain. And going to your second question, sorry, it was monitoring, right?
Yes.
Okay. The best monitoring is actually the patient. Right? So
I see.
patient, yep. So I do not use any form of sedation on them. I do not use any, I mean, GA is completely contraindicated for me. I do
Yes.
know, I do understand some pain practitioners, they do use awake sedation. Even some even go to the extent of general anesthesia because they say patient is more comfortable. Then only then probably you need to talk about neuromonitoring and all. But as long as the patient is awake, patient will tell you, and especially if you're going to go ahead with radiofrequency ablation, right? So to identify that you've hit the sweet spot, patient needs to be awake. You induce the pain, and patient tells you that, look, this is the pain. Then you can very confidently say that, okay, now I'm going to really give you relief for pain, right? Likewise, when you're going to give just medication, local anesthesia and steroids, the same thing. Normally when you hit there, they'll tell you roughly, yeah, this is where the pain is. This is the thing which is bothering me a lot.
Yes.
Then you, with some relative amount of confidence, you know that the pain is going to be relieved to a certain extent.
Yes, and yeah, you're right. Even though the duration of the anesthesia that is only the anesthetic agent is 4 to 6 hours, then it's important to break the pain cycle. So yeah, that's very important. And thank you so much.
Yes, and the other thing is the steroids. It'll take a couple of days to take effect, and they tend to last for a much longer period of time. So again, you need to inform the patient, look, the pain will come back after a couple of hours, but after which it will gradually subside with the anti-inflammatory agent.
I see. Thank you so much.
Do you have another question from audience?
Yeah, I think
Dr. Sam?
Yeah.
Thank you, Prof. Gato. Prof. Palami, thank you so much for your lecture. I would just like to ask, how do you decide which levels you do and whether unilateral or bilateral? Because I think the facet joints are quite close to each other. So how do you decide whether it's 3, 4, 5, you would block, or only do 3, only do 4, you do 7? Because clinically, sometimes it's difficult to determine.
I mean, it's a combination of both history as well as clinical examination. First of all, ask the patient to point out where the pain is, right? And then again, palpate and ask the patient which is the area which is of most concern. So they need to be aware that we'll be inducing pain prior to the procedure. And whether to do bilateral, unilateral, that's actually entirely up to the patient to tell us which is actually bothering them the most, instead of just going blanket and injecting everything. Obviously the pain subsides, but you do not have so much of a diagnostic value to it. Because the next time, if you want to relook and if you want to do a radiofrequency ablation and whatnot, where the risks are a bit higher, you would want to go for a very targeted approach.
Okay, thanks.
Okay. Thank you, Professor Kamaransan, for nice education, how to control the neck pain by the facet blocking. Thank you, Professor.
Thank you.
The last speaker is Professor Aya Hashimoto. Last month, many Japanese neurosurgeons visit to Shanghai and Suzhou with Professor Kato to make the friendship between two countries. Maybe I think that this is a report from the conference and the hospital tour. Please start, Professor Aya Hashimoto. Please start.
Can my slide share my slide?
Yes.
Let's start. My name is Ai Hashimoto from Kurume University, Fukuoka, Japan. It is a great honor to be able to speak today. I speak my experience of attending conference and visiting hospitals in Shanghai and Suzhou from June 21st to 23rd this year. First, a brief self-introduction. I've been a doctor for 10 years, and I'm currently working at Kurume University Hospital in Fukuoka, in West Japan. I currently specialize in endovascular surgery and endoscopy and skull-based surgery. So the members who visited China for this conference were Dr. Suresh from India, and Dr. Liu and his wife from Malaysia, and Professor Yoko Kato from Japan, with 8 neurosurgery gathering in Shanghai. A few more people were supposed to came from Japan, but they couldn't due to visa issue. This is the schedule for ACNS Shanghai, and social academic symposiums. The ACNS was held in Shanghai and Suzhou on June 22nd. The event not only including a conference, but also dining and sightseeing. After arriving at the first place, we eat French coast. Afterwards, we were taken a bar with a view of Shanghai Towers. The night view was very beautiful, and since it was weekend, so there are many people, so Chinese young people. We are able to so many beautiful view and interesting canvas stations. On the morning of June 22nd, we visit Fushan Hospital and of the Fudan University and toured the hospitals. Fushan Hospital is the largest neurosurgery hospital in southern China. This is a hospital model. This wall building is for neurosurgery. This is a video created by Shanghai team. They had decided cameramen who took a beautiful video on the day our visit. So very high quality video. So they are presented for us. Many people so presentation and Japan, Chinese, and India. So very useful part. This is a video my edited visited for the hospital. The entrance, this is a hospital that was very clean and wide. And they gave us detailed explanation of the hospital. There were very clean cadaver station and so very wide. And so there were a lot of neurosurgeries and staff working there, and their team was subdivided. What surprised me the most was the number of operation rooms. This picture is operation rooms. There were 34 operation rooms just for the neurosurgery department. And each operating room was white, one well equipped. And the nurse also welcomes us very warmly. After the tour, the ACNS conference began in a round table format. It began with a greeting from Professor Yoko Kato and Professor Zhang Wang and Professor Yao Zhao. So Dr. C is very kind and extremely accommodating the conference to dinner. So 18 speakers gave presentation and engaged in lively discussion. The program ended with the signing ceremony of the memorandum of understanding between the ACNS and the Fudan Hospital of the Fudan Universities, represented by Professor Yoko Kato and Professor Mao Yan. Thank you for Fudan Hospital staff and ACNS China team. So we after lunch, unexpected event can happen when traveling. The doctor who left early for work, he forget his bag, so contained his passport. So we contact his. This is his passport. So the Fudan Hospital staff delivered passported by ambulance. He got his passport back so he could board the plane to Japan. After that, the rest member traveling by bus, so Shanghai to Suzhou. And the first affiliated hospital of Suzhou University was also a very large hospital. We held a round table conference in Suzhou, and the conference starting a greeting from Professor Zhang Wang and Professor Yoko Kato. There are quite a few medical students, social university, who activity ask questions.
The male or female who likes the neurosurgery, never very tired.
They sometimes answer in Japanese. The program ended with sign ceremony of the memorandum of ACNS by Professor Yoko Kato and Professor Jiang Wang. The medical students from Soshu University were highly motivated and impressed. And at night, we ate Chinese food in the center of town, where the gate of the Oriental is located. This is a twin tower and seemed to be popular with young Chinese people. One thing that surprised me about Chinese culture was the culture of cheers. This is a baijiu, a higher alcohol content luxury drinks. It's often used for entertaining guests. It seems to be a unique etiquette to the campaign. This is a campaign movie. We can say campaign and click your glasses together and they drink all the alcohol in the glass. So we did many times campaign with him. So and we ended up hitting it off. So we remember Dr. Otani who was in room next to us. She campaigned more than 10 times. Thank you for the first affiliated hospitals of Social University staff and ACNS China teams. On last days, we did something sightseeing social. So we go walking around the old street of social. So it is very beautiful street. And there were many souvenir shops. We looking at for. And we go Shuzo Museum. This museum was established in 1960. And the Shuzo Museum has about 24,000 pieces set of objects. Finally, we take a picture and eat local news. So we visited for former past. We visited former affiliated school university, and the building remained as it was when Professor Yoko Kato studied abroad. I felt it was important that some things remained unchanged from the past. After this, we broke up and each go home. This is my first visit. Unlike Japan, where there are many hospitals scattered around, doctors and equipment were concentrated in one hospital. And visiting the few hospitals, I like any I've ever seen before. So made me recognize that my world is small and that I would like to visit more countries. Although medical systems differ from country to country, I felt that everyone shares the same desire to pass further technology and research through the conference. I would like to take this opportunity to express my gratitude to Professor Yoko Kato for giving me this very opportunity and to Professor Dr. Liu for making various arrangements and to Chinese ACNS members and to other professors who participate with me. Thank you so much.
Thank you, Professor Hashimoto. Nice report of our friendship meeting. Do you have any comment or Professor Yoko Kato, do you have any comments to this, the workshop?
Okay, thank you very much, Chan. The wonderful report. I think that you were the most enjoy. I think that during the trip, I think, and I think exposure during the younger age and the exchange that took several countries. I think it's really very important. As Asians, maybe the 2-3 times per year, maybe on site visiting, we will plan in the future. Thank you very much, Aichan.
I'm glad that I able to have a very variable experience. Thank you.
Professor Ben, do you have some comment or?
Just want to say congratulations between the ACNS and the Chinese hospital. Just one question is that I want to ask if there is any agreement about the exchange between the ACNS member and Chinese hospital assigned during the meeting. Any agreement between, because I think I remember I knew Dr. Liu. Dr. Liu told me that you were in Shanghai and Suzhou when I have a meeting in another city in China. So I really interested in this in your meeting in the ACNS in Shanghai. So I would like to ask about some details. And I think the one who lost the passport is it a Professor Watanabe? Can tell Watanabe?
Sugawara.
Oh, Sugawara.
Sugawara sensei. Yeah. It was really fun. Thank you.
Yes. And any exchange between the China agreement about the exchange
yes,
of
yes, we did. That, yes, MOU in the two universities. As I said, I think in the future maybe we'll have a more MOU in between the several universities. I think.
I see. Thank you. Interesting. Congratulations.
Yes. Next time for you, I think.
Yes. Do you have another? Is there another comment or?
Dr. Liu, maybe you can have one word, please.
Yeah. So sorry. Yeah. Thanks. Actually, I'm very honored to be able to join the program, and hopefully we can have more such program in the near.
Okay. So is there any comment, Professor Ahmad?
No, thank you. It's very excellent presentation, and I also like to know about the exchange program and training in China, because China is our neighbor, and it's easy for Afghanistan neurosurgeon for training and also exposure meetings, and education is very good. If we have some facilities in China, it's be very good.
Yes. I think maybe in the future that China can support your country, I think, a lot of countries. Yes. Thanks so much.
Thank you.
Okay, thank you. So
thank you. So then now it's time to close this webinar. Professor Ben, do you have some comment to close this webinar?
Yes. So I think it's now time for the end of this ACNS YNS webinars. So I really appreciate. So we have 4 lectures today, and really appreciate the expert speakers, the YNS speaker, and also the chair, Professor Koto. Thank you so much for your help, and indeed it's a very educational and meaningful webinar. And I think and I also think that for the last session, Dr. Aya's presentation about the sharing of the ACNS activities. is sometimes it's not common to have these webinars about the sharing of our ACNS activity. I think this is very interesting and very attractive, so that people all around the world will know more about our association, and it's a very great sharing as well. So of course, not to mention all the expert speaker about the expert knowledge of the scalp and also and the pain surgeries. So this is a very educational day, and very wonderful webinars. So I'd like to thank you, all of you, for joining us on behalf of the educational community of ACNS. So I hope to see you all in the next ACNS YNS webinars. Any last word, Professor Kato? It's a very wonderful.
It's fine. Thanks so much. So we learned a lot from 4 speakers, including Aya Chen. I think maybe the next time we will have a very fruitful the webinar. I think. Thank you very much.
Thank you so much.
Thank
So
you.
it's goodbye to
後藤先生、ありがとうございました。
ありがとうございました。
はい。おやすみなさい。